So, today's topic is totally different from what we have discussed last day. Today's topic is congenital disorders of the genitourinary tract. শুনতে পাচ্ছ সকলে? Am I audible? Okay. So, I will divide this topic into two classes. In today's class, I shall discuss the development of the kidney ureter and the associated commonly encountered anomalies that we find in clinical practice, how to identify them and how to treat them, rather how to evaluate them. So, first and foremost, what comprises of the genitourinary system? It is well known to you the components of the body that comprise of the genitourinary system: the kidney, ureter, bladder, prostate, seminal vesicles, urethra, penis and testis, and these organs have a huge number of anomalies which are congenital in nature since birth. I would like to start my class by asking some of you a few questions. Can anybody enumerate or tell me the functions of kidney in the body? What is the function of the kidney in the body? Please somebody volunteer. I don't know your names, otherwise I would have called up one of you. Somebody would like to volunteer. What is the function of the kidney? Stand up. একটু উঠে দাঁড়িয়ে বলো। Excretion. Excretion of what? Excretion of waste products. Very good. So that is the it's the top heading. Okay. So elimination of metabolic waste from the body is a function of the kidney. Any other function of the kidney you know? Yes, erythropoietic secretion. For what purpose does it solve? Yes. Yes. Very good. Anything else? Very good. Electrolyte balance. Anything else? Any role in vitamin D metabolism? What role does it play in vitamin D metabolism? So what exact role does it play? It performs a specific hydroxylation. 1 আর 25 এর মধ্যে একটা hydroxylation kidney. Anyway, so the point of the matter is that the kidney is not just an organ for elimination of toxic waste. It has a lot of other functions as well, and for which it is a very essential organ in the body. Similarly, other systems, other organs also have a primary and secondary. So we shall start our class today with the basic recapitulation of how embryologically these parts of the body develop. So the development of the kidney is a very complicated process. So it develops in 3 phases. What do I mean by 3 phases? That the humans since birth developed 3 sets of kidneys. The first 2 sets of kidneys represent the renal counterpart, the kidney counterpart in primitive mammals, which are gradually obliterated, and the newer versions, the iPhone 16 version comes up at the end. So the first kidneys that appear in the human body is called the Pronephros. So all the kidneys develop from the mesoderm. What are the 3 layers in the body? Yes. So it develops from the mesoderm, and a specific part of the mesoderm is involved in giving rise to these kidney structures. It is the intermediate mesoderm. Okay. So which gives rise to all the 3 parts of the kidneys. So first, in the small body that is formed, the cervical region has a structure that is identified as the pronephros. The pronephros develops primitive tubules and a cord which eventually gets obliterated with the appearance of Mesonephros. So, Mesonephros also has a mesenchymal body and a mesenchymal cord. This cord is called the mesonephric duct, also called the Wolffian duct. Yeah. So, Wolffian duct is gives rise to. So, what happens? Yes. So, this mesonephros, uh, it comprises of two structures, as I told you, the nephric ducts, which precedes the development of the mesonephric tubules. The nephric duct, it appears as a solid longitudinal tube on the back side of the body, and this tube meets the cloaca at the distal end. What is the cloaca? Cloaca is the common genitourinary outlet channel. So, this particular tube, so this is the cloaca, and this particular tube opens distally into the cloaca. This is the mesonephric duct or the nephric duct. Okay. And there is canalization of this duct starting from distal to proximal. Okay. দেখা যাচ্ছে না? সেরকম দেখা হ্যাঁ হ্যাঁ। So, this is the cloacal opening, this is the mesonephric duct. This mesonephric duct is initially a solid cord which gradually develops, which gradually canalizes from distal to proximal. Okay. And it is associated by formation of around 40 tubules starting from cranial to caudal. বোঝা যাচ্ছে? এবার these tubules, they start developing from the cranial end, progresses towards the caudal end. As the development progresses towards the caudal end, the cranial tubules obliterate. Okay. Some of these cranial tubules give rise to other structures of the genitourinary tract, like the seminiferous tubules are formed from the tubules on the cranial part. Okay. So, the mesonephric duct gives rise to the vas deferens and the epididymis, and the mesonephric tubules from the mesonephros gives rise to the seminiferous tubules. So, this gives an indication of development of the testis also, a part of it from the gonadal ridge, and these mesenchymal tubules eventually obliterate. This occupies the region of the thoracolumbar part of the body. After disintegration of these tubules, the metanephros, which is located around the sacral region, that becomes active and forms the eventual and final addition of the kidney in an adult human being. So, initially pronephros, then mesonephros, and lastly metanephros. This I just told you. Okay. So, the metanephros, it is occupying the sacral region of the body, and the distal portion. Okay. So, the metanephros is responsible for formation of the final kidney. Kidney formation involves two very important developments. It forms from two structures. One is the metanephros, as I told you, and the other is an outpouching from the lower part of the mesonephric duct. Okay. So, this is called the outpouching, this is called the ureteral bud. What happens is, this ureteral bud grows towards the metanephric tissue and it divides. How does that happen? The distal portion of the ureteric bud arises bilaterally. It is on both sides, this one for the right, one for the left, and they come in contact with the condensing blastema of the metanephric mesenchyme. Okay. Subsequently, after they come in contact, this duct divides into branches, and eventually by further division of this ureterial bud, the calyces are formed, and the cortical portion of the kidney is provided by the metanephric blastema, and the collecting system is formed by the ureteral bud. So, now the question comes is, this part is important for your competitive exams. So, up till what portion of the collecting system is contributed by the ureteral bud, and what remaining part is contributed by the metanephric blastema. So, the division of this ureteral bud initially happens into two, which forms the primitive pelvis. Further division gives rise to the major calyces. Division of the major calyces gives rise to minor calyces. Further division of the minor calyces gives rise to the collecting duct system. So, the division of the ureteral bud forms up to the collecting ducts. So, I hope everybody here remembers the structure of a nephron. What are the components of a nephron? Yes, Bowman's capsule and glomerulus. So, the remaining part of the functional unit of the kidney proximal to the collecting ducts are formed by the metanephric blastemal tissue. So, each new formed collecting tubule is covered at its tip by metanephric tissue cap. Imagine this to be one of the terminal collecting tubules. This is covered by the blastemal cap. Now, what happens? There is induction of this cap on coming in contact with the ureteral bud tissue, and this gives rise to small renal vesicles around the ureteral bud, along the collecting duct opening. These vesicles eventually turn into tubules. Now, joining of these tubules with the collecting duct eventually form the Bowman's capsule, and the growth of capillaries into the Bowman's capsule to provide vasculature gives rise to the glomerulus, and this glomerulus, Bowman's capsule, collecting duct, entire thing together forms the nephron, which is the functional unit of the kidney. So, this mechanical growth of the ureteral bud, the transformation of the metanephric blastema, all these are guided by signaling pathways. Okay. So, this is a pictorial demonstration of what I just tried to explain to you. The yellow portion, collecting ducts, till that is by the ureteral bud, which arises from the metanephric cord, and the remaining part, the Henle's loop, the Bowman's capsule and the glomeruli, comes from the metanephric blastema. Okay. These are the stages of development of the nephron I just told you. So, this is a summarized picture of the basic developmental process of the kidney. What happens? To summarize, what happens? The first picture shows that the mesonephric duct and the ureteral bud growing into the metanephric mass of intermediate mesoderm. Next, the ureteral bud splits into the renal pelvis, then the major calyces, then the minor calyces, eventually giving rise to the functional unit of the nephron. Okay. So, after the development of the kidney, another very important thing happens with the growth of the fetus. So, where did we say that the metanephros or the final kidney is forming in the body? It is forming in the pre-sacral region, in the sacral region. But where is the normal location of the kidney in the human body? Lumbar region. So, what needs to happen for the kidney to reach the lumbar region? the kidney needs to ascend. So, two things happen simultaneously as the kidney ascends. One is it goes up from the sacral region to the lumbar region, and the other thing is the kidney initially is facing with the pelvis in front. Imagine this is the pelvis, it is facing, the pelvis is facing anteriorly. So, the kidney ascends and the pelvis turns medially. So, there are two things happening simultaneously. All this is important. Why? Because any deviation from this normal sequence of events give rise to anomalies in the kidney structure. Okay. So, another thing that happens is, suppose the kidney is in the sacral region and it ascends to the lumbar region, but for that the kidney needs to have a then very long vascular pedicle. The kidney pedicle, the renal artery and the renal vein, at what level does it arise? From where does it arise and at what level does it arise? It is at the level of L2. Okay, renal hilum is at the level of L2, whereas the initial level was at the sacral level. So, it is not like that the same vessel is pulled by the kidney from the sacral to the lumbar region. What happens is, with gradual ascent, new vessels develop into the kidney and the previous vessel obliterates. Again with ascent, the previous new vessels develop. So, there are new vessels developing along the course of the kidney from the sacral to the lumbar region. Okay. So, three things that happen other than formation of the kidney is ascent, rotation and vasculature changes from the lower to the upper region. Okay. So, with this basic background knowledge in mind, I hope there was a small recapitulation of the development of the kidney. With this in mind, we shall delve into some of the most commonly encountered anomalies. So, the anomalies of the kidney and the ureter can be classified into anomalies of dysgenesis, anomalies of shape and position and anomalies of the collecting system. So, first we come to anomalies of dysgenesis of the kidney. Okay. Renal agenesis, it means that there is, the kidney does not form totally, it can be unilateral or bilateral. So, have you ever heard of anybody who has bilateral absence of kidneys? It is not supported, it cannot support life, but it does happen. It happens in fetuses who are probably part of a sequence syndrome called Potter's syndrome. So, where does the amniotic fluid come from inside the womb? Do you know? What is the source of amniotic fluid? So, the kidneys actually provide this fluid for the amniotic fluid. The fetal kidney produces the bulk of the amniotic fluid. So, in the absence of both the kidneys, what happens is there is severe oligohydramnios inside the womb. In plus there are other organ deformities as well. So, because of severe oligohydramnios, there is crushing of the fetus inside the womb, and this particular facies, where the facial features, the bodily structures appear as crushed and wrinkled, along with absence of bilateral kidneys and several other deformities, we call it Potter's syndrome. This is very rare and we do not deal with it regularly. However, unilateral agenesis of the kidney is commonly encountered in clinical practice. So, why does this happen? It happens because when either the ureteral bud does not migrate towards the metanephric blastema, or the signaling pathways responsible for activating the metanephric blastema on contact with the ureteral bud, it does not function. So, there is agenesis of that sided kidney. The second type is renal hypoplasia. What does hypoplasia mean? So, this kidney does not have any reduced functional capacity. The nephrons are functional, the size of the kidney is smaller than normal, and the number of nephrons may be lesser, but functionally they are a capable kidney. Okay. So, there is no structural or functional anomaly, just a decrease in size of the kidney. What can this be associated with? Because there is the size of this kidney is small, there might be associated hypertrophy of the contralateral kidney in such cases. However, this is not clinically significant. Some patients get diagnosed with this condition because of hypertension. The smaller nature of the kidney may give rise to hypertension later on. Third type, renal dysplasia. What does dysplasia mean? Dysplasia means loss of functional capability. Okay, so this kidney is not small in size, it is same size or larger in size. However, it is not capable of performing the functions of the kidney. Why? Because of the architectural orientation of the kidney is lost in these patients. Here the cysts, it comprises of multiple cysts in the kidney, and these cysts do not connect to each other, or it does not connect to the structure pelvic-calyceal system. So, the function of formation of urine and drainage of urine is not performed by this kidney. One of the variations of this is a multicystic dysplastic kidney, and it is one of the most common causes of abdominal masses in infants. Okay, palpable mass, abdominal mass in infants is often caused by MCDK. What is the problem of such patients? What do these patients present with? These patients present with intracystic bleeding leading to pain abdomen, infection leading to fever, sepsis and the infection cycle, and less commonly, however, is encountered in clinical practice is malignant transformation of this kidney. So, previously it was recommended to remove or perform a nephrectomy for these kidneys. However, nowadays we prefer to follow it up and look for signs of the transformation. So, these three are common varieties of dysgenetic kidneys. Fourth one is the most commonly encountered and most important for you as well, is polycystic kidney disease. Okay. So, polycystic kidney disease, it is of two types. It can be an autosomal dominant variety and autosomal recessive variety. Autosomal dominant variety is quite common, autosomal recessive variety is rarely seen in practice. Autosomal dominant form has a variable penetrance. What do you mean by variable penetrance? It means that two individuals can be diagnosed with polycystic kidney and have the same genetic structure for having polycystic kidney. However, the expression of the disease, the magnitude of the disease may be different in different individuals. You might have the same structure in the gene, but your expression might be different. So, how can the expression be different? It can be different regarding the number of cysts that are affecting the kidney. It can be different regarding the involvement of other organs in ADPKD. So, what is important is a person diagnosed with ADPKD or polycystic kidney disease is not probably suffering from only kidney disease, and this is the most important take home message for this disease. Okay, because once you are in clinical practice, you will get an ultrasound saying this patient is diagnosed with polycystic kidneys. So, at that point of time, you will have to start thinking of involvement of other organs and try to exclude any other involvement that might provide a risk to life or that might be harmful for the patient. So, now coming back, Autosomal dominant variety, it is caused by mutation of the PKD1 or 2 genes, and it is autosomal dominant with variable penetrance. Okay. So, this is very important for your entrance examinations. It is a multi-system disease. What are the systems involved? Kidney is always involved. Other than that, it involves the liver, pancreas and the brain. Okay. So, what are the renal manifestations of polycystic kidney disease? There are cysts in the kidney, we know, but how do these cysts present themselves as symptoms in the patient? The presence of cysts increase the size of the kidney, but leads to decreased functional capacity of the kidney. Okay. So, there is enlargement of the kidney, it might be a palpable mass in the abdomen, it may give rise to pain in the abdomen, and these cysts might often have intracystic hemorrhages, which gives rise to acute painful episodes. It might bleed into the collecting system, causing hematuria. Presence of abnormal structural anatomy in the kidney might give rise to urinary tract infections. It might be a cause of hypertension, stone disease, and as initially mentioned, decreased renal function involving both kidneys may end up in end stage renal disease or CKDs. So, it has a vast spectrum of presentation, not one presentation, but vast spectrum. However, most commonly 3 things are encountered. One is pain, constant dragging pain, 2 is hematuria, and 3 is palpable mass. These are the most common presentations of polycystic kidney disease. And commoner than that is asymptomatic and incidental diagnosis of cysts. And now, what are the extrarenal manifestations of polycystic kidney disease? As I previously mentioned, the patient might have cysts in the liver, and the patient might have intracranial aneurysms, and also valvular heart diseases, most commonly a mitral valve prolapse. So, this is where studying this topic becomes important. Why? Because performing an ultrasound and finding more than 3 cysts in both the kidneys or more than 2 cysts in each kidney will give you a diagnosis of polycystic kidney disease, that the patient is asymptomatic. What do I do with this patient? I need to exclude the other imminent problems, because an intracranial aneurysm is a time bomb. I need to diagnose it before it becomes symptomatic. Okay. So, similarly, because of variable penetrance of polycystic kidney disease, the ADPKD variant, many patients will not be symptomatic or will not have any evidence of the disease till 30 years of age, and gradually the symptoms develop after 30 years of age. Few of them develop end stage renal disease after 60-65 years of age. So, there are a population of patients suffering from this disease who do not get diagnosed of it throughout their lifetime, or they do not have any symptoms from this throughout their lifetime. However, this is not true for the autosomal recessive variant of this disease. Autosomal recessive variant is very aggressive, and you hardly encounter any patients who are adults suffering from that disease, because they do not survive. Okay. So, from the anomalies of dysgenesis, from your point of view, polycystic kidney disease is important because it often comes as short note. You need to prepare that topic separately. Now, we come into anomalies of shape and position of the kidney. From the developmental background, you can jolly well understand the kidney will have numerous anomalies. We cannot enumerate them properly as to the number of anomalies that can happen with shape and position. So, I will just jot down, I will just discuss a few among them. Ectopic kidney. What do you mean by ectopic? It is that the kidney is not in its original position, stipulated position. So, it can be anywhere in the path of its natural ascent, right. So, it can be a right sided kidney, maybe anywhere from the sacral region to the lumbar region, anywhere along that tract. That can be one type of ectopic, and it can deviate from its path as well. That can be another type of ectopic. So, most commonly the kidneys are ectopic because of failure of ascent, and they, since they fail to ascend, they remain in the pelvic region as the pelvic kidney. Less commonly they are stuck in the iliac region, or sometimes, as I just mentioned, they might deviate from their path and cross over to the other side of the abdomen to form a crossed ectopic kidney, and rarely it is not failure of ascent, but over ascent, and the kidney enters into the thorax for being a thoracic kidney. Okay. So, what is the problem if the kidney is not in its actual position? Is there any problem? No, finding is incidental, but is there any problem for the kidney being in a position away from its normal position? Actually, from a functional point of view, there is no problem unless the kidney is having some other associated structural anomaly with it, which is common. Okay, so only a deviated kidney located in a location, placed in a location away from its normal location is not a problem unless this kidney is associated with, say, reflux. This kidney is associated with an obstruction of the pelvic ileal system, giving rise to hydronephrosis, etc., etc. Okay. So, simply an ectopic kidney is not so much of a problem. Now, this is another type of structural anomaly of the kidney. Once again, this is separately an important topic for you. What is this? It is called a horseshoe kidney. So, I forgot to mention how does the ascent of the kidney happen? What is the main driving force behind the ascent of the kidney? It is the physico-mechanical forces that act on the kidney because of differential growth in the abdomen. So, this same force, the same mechanism pushes the kidney up and pushes the testis down. Okay. So, descent of the testis and ascent of the kidney, the main driving force behind it is the mechanical forces generated by changing of the abdominal girth structure of the abdomen with growth of the fetus. So, with this external force and external mechanical forces on the kidney, it often so happens that the two lower poles of the kidney are compressed and fused together. Once the lower poles of the kidney get fused together, the ascent of the kidney is naturally restricted by structures that lie in the midline in its path. So, what structures can lie in the midline in its path of ascent? So, most commonly the inferior mesenteric artery provides a hindrance to this conglomeration of the kidney to rise upwards towards the lumbar region. Okay. So, the horseshoe kidney again possesses two structural problems. I mean differences. What? One is the location, that it is located below in the pelvic region, and two is this kidney did not have the opportunity to rotate. So, once again for them the pelvic ileal system is not medially located and protected, it is either anterior or lateral. Okay. So, what does that do? It poses a threat to external obstruction to the pelvic ileal system from other structures of the body. So, often this horseshoe kidney is associated with hydronephrosis because of either obstruction due to a pelvic ureteric junction obstruction associated with this horseshoe kidney, or obstruction from external other organs of the body. uh, it is also complicated by very commonly with stone formation. Okay, so horseshoe kidney with stones is a very common clinical patient. So, what other things might be important for you? Yeah, the other important thing is that for every kidney, the blood supply is very defined in case of kidney. We have one or two or say three definite renal arteries supplying the kidney once it is in the lumbar region. However, for a horseshoe kidney, this is very haphazard and there is a leash of blood vessels entering into the kidney and supplying the kidney from the pelvic vessels as well as the aorta. Okay, so the iliac vessels and the aorta all supply the horseshoe kidney because of non-ascent the newer blood vessels had formed, but the previous blood vessels had not obliterated. So, all of them are present and a leash of blood vessels, multiple blood vessels supply the kidney. So, why is this clinically important? How does it matter if the kidney is supplied by one artery or it is supplied by 1, 2, 3, 4, 5 arteries? What is the clinical significance of this difference? No, so I am a surgeon. For me, this is very significant. Anybody? For me, this is very important. Transplant, yes, it means from a surgical point of view, if I am operating on a kidney with a single artery, I know that I have to preserve the structure that is entering the kidney to preserve the kidney itself. So, I am very cautious. If I somehow cut this structure, then I am actually stopping the blood vessel, entire blood supply to that organ. So, when we are trying to remove the kidney, this is important, whereas when we are trying to preserve the kidney and do some other operation, that time also it is important. Whereas for this condition, I might have blocked these two arteries and then tried to remove the kidney, but it will bleed because I have not taken out other branches and there is no definite rule to how this horseshoe kidney will be supplied. So, what is the actual clinical problem? The actual clinical problem is if I am trying to do some other surgery and by chance I cut this vessel, what happens? No, by chance I ligate this vessel. I do not know, I have taken down this vessel without my knowledge. Yes, why? There are other 4 arteries supplying the kidney. Yes, because renal artery is an end arterial system, very important. So, because this artery is supplying a specific area of the kidney and the other arteries will not interfere to supply the same area of the kidney. It is not so with the venous drainage. The venous drainage is amalgamated. However, the renal arterial system is end arterial system. Did you get my point? Did you get the clinical significance of having a single or 2 arteries and multiple? Okay. So, horseshoe kidney that is why it is important for the surgeons because it has multiple vessels, it is abnormally placed and it is prone to diseases which require surgical intervention. The third type of anomaly, what is the time? Third type of anomaly is a crossed fused ectopic kidney. Ectopic kidney we have discussed. So, here you can see the kidneys can go anywhere and get deranged from their path and go anywhere. So, both the kidneys can end up on one side, and get fused with one another. So, one is with fusion, one is without fusion and it might be bilaterally crossed or a solitary crossed. So, it can go both ways. This again is also surgically important, because in the age of endourology, if a patient is suffering from stone disease in this kidney with a crossed, it becomes a very difficult access to that patient. So, normal presence of these anomalies is not the problem. However, once the kidney is affected by some secondary disease because of these anomalies, the treatment becomes difficult. Okay. So, what is the cause? Again, this abnormal development of the ureteric bud and metanephric blastema. Now, we come to anomalies of the collecting system. This is a very interesting part and uh, den for MCQ questions again. So, this ureteric bud we have discussed till now normally touches the metanephric blastema and then divides into two to form the pelvis, renal pelvis. However, in cases of an anomaly, this ureteric bud might bifurcate before it actually reaches the blastema. So, what happens if it bifurcates? It can give rise to duplication of the renal pelvic calyceal system. What are the range of duplications? It can be just that the renal system is duplicated at the level of the kidneys, just two ureters entering the kidney, and it can be total duplication as well, that the kidney is almost separated into one kidney is separated into two kidneys and two different ureters drain the kidney and it reaches the bladder at different points. Okay, so one is complete duplex and the other is incomplete duplex. This anomaly is very interesting. Why? Because the location of entry of the ureter in the bladder is guided by a law called the Weigert-Meyer's law. Okay, you must have read regarding Weigert-Meyer's law. So, what happens in what the Weigert-Meyer law describes is that suppose the kidney is like this and the calyceal systems are separated into two like this. Okay. So, the law states that the upper and lower. So, the entry into the bladder is that the upper one will enter the bladder distally and medially, and the lower one will enter the bladder proximally and laterally. Okay. And the upper one is most commonly associated by an anomaly called ureterocele at its distal end, whereas the lower one is commonly associated with an anomaly of reflux. Okay. So, the duplex system can be complete, can be incomplete. Incomplete ranges from from just bifurcation to duplication of the ureter with a common entry into the bladder. The moment the entry of the ureters in the bladder becomes separate, we call it a complete duplex, and the complete duplex entry of the bladder, the entry of the ureter into the bladder is guided by this law. So, why is this important for us? True. So, this ectopic ureter can enter anywhere in the pelvis proximal to the level of the sphincter, okay, to the rhabdosphincter. Now, what happens in females is, if the ectopic insertion is into the urethra, females do not have an external sphincter just like males. So, these patients present with incontinence, continuous dribbling incontinence. So, that is one importance. The other importance is, suppose there is a stone over here. You as a surgeon you have identified that the patient has a stone in the lower calyx and the patient has a duplex ureter. So, you will have to identify or know which opening of the ureter will lead you to that stone. বুঝতে পারছো? Why is this law important? Which opening will lead to which stone? Now again, suppose there are two openings in the bladder and both the pelvic calyceal systems are normal in structure and doing well. Is there any problem? There is no problem. Both the kidneys are, both halves of the kidney are draining urine properly. So, there is no problem. The problem arises because of these two associated anomalies, ureterocele and reflux. I shall discuss these in details in the next class. So, ureteroceles are most commonly obstructive in nature. It hinders the flow of urine in the ureter. So, once that happens, if there is an obstruction in the flow, what happens? Hydroureter and hydronephrosis develop. What happens with progressive hydronephrosis? There is loss in functional capacity of the kidney. Eventually, half of the kidney gets lost. Similarly, the reflux, if the patient is having reflux, what do we mean by reflux? Very good. So, the reflux also essentially leads to deterioration of renal function eventually. So, then again we have to identify that what is the main problem. So, you get my point. When do these duplex system become pathological? Once it is associated with these anomalies like ureterocele and reflux, and it leads to progressive deterioration of renal function. Now, this is possibly the most commonly treated, commonly operated congenital anomaly other than phimosis by the urologist. What is this? Ureteropelvic junction obstruction. Okay. None of you have been to the OPD here, right, before? Have you, do you have OPD postings? You have OPD postings. Or what, I don't know whether they have had these patients or not. So, what happens is, in this patient, there is an obstruction at the level of the pelvic-ureteric junction. There is narrowing of the tunnel carrying urine at the level of the pelvic-ureteric junction. Why does that happen? Why does that happen? So, any obstruction, if in your examination anywhere you have to write down causes of a lumen getting obstructed, you should gather your thoughts and start thinking in basic 3 headings. What are the 3 headings? The obstruction might be intraluminal, it might be the wall, or it might be extraluminal. Okay. Whatever may be the question, it might be in the brain, it might be in the leg, wherever. If the question surrounds something that is a tubular structure and it leads to obstruction, so the causes will be under 3 headings: intraluminal, wall causes and extraluminal causes. So, similarly, for this we have 3 causes. What might be the 3 causes? What might be an extraluminal cause for PUJ obstruction? Most commonly, yes, it can be a tumor, but we are dealing, today's class we are dealing with congenital obstructions. So, what might be a cause of congenital obstruction in the PUJ? Very good, actually. Tumors are very commonly obstructing the ureter extraluminally, but in this case, for a congenital cause, we have to think of something from what I have taught you development wise. Horseshoe kidneys can have, but what is causing that extraluminal obstruction? Most commonly. So, I told you during ascent, the lower arteries are dissolved and the new arteries develop as the kidney goes up from below upwards. So, what happens is this new vessel has developed, but the previous vessel has not disintegrated. So, an aberrant renal artery, presence of an aberrant renal artery often gives extraluminal compression on the ureter and causes a kink in the ureter and a block in the ureter, giving rise to a pelvic-ureteric junction obstruction. Okay. This is one cause, and the other most common cause is wall cause. There is fibromuscular degeneration of the wall of the ureter at the level of the pelvic-ureteric junction. So, these two causes lead to an obstruction in the flow of urine from the kidney into the ureter. What does that lead to? It leads to stasis of urine and hydronephrosis. So, I will give you a definition of hydronephrosis, which you have to remember till your exams at least. So, hydronephrosis is an aseptic dilatation of the pelvic calyceal system. What do we mean by aseptic? It is not infected yet. Okay. So, once it gets infected, we call it pyonephrosis. So, we are dealing today with PUJO or pelvic junction obstruction. It leads to progressive decline in renal function of the affected kidney and enlarging of the pelvic calyceal system due to hydronephrosis, eventually leading to a non-functional kidney. So, can anybody tell me how do these patients present to the doctor? I want other people to participate as well, only he is answering and you are answering. Other people, if they want, if they have idea, they can also participate. So, how do patients with PUJ obstruction present to the doctor? In today's world, the most common presentation is not by the patient, but by the mother when the patient is still not born. The baby is in the womb. How does that happen? Because of antenatal scans. Okay. So, antenatal scans, with the advent of antenatal scans, we can diagnose these patients in the womb to have hydronephrosis. Yes, antenatal hydronephrosis. Antenatal hydronephrosis have a lot of causes, 9 to 10 common causes, out of which one of the commoner causes is this. Okay. Second presentation after birth, just like any other patient of hydronephrosis present, it can be pain, infection, hematuria, palpable mass. Any kidney enlargement patient will present with either of these symptoms. Okay. So, what do we do? How do we treat this patient? So, what do you mean by causing any problem? True. So, we treat these patients on specific criteria. If there is deterioration of renal function because of the presence of this, which means that if there is a specific test called DTPA renogram, on performance of the test we get to know the split function of the kidneys. What is the GFR of your right kidney and what is the GFR of your left kidney? We get to know that separately. Once we see that the one kidney affected by this disease is having significantly lesser function than the other kidney, it means that it is losing its function because of this disease, then we intervene. Okay. So, this is the most important crux of intervention. And what do we do? What kind of surgery do we do in this case? I am asking you this because this is one of the few surgeries that might be asked you at an MBBS level. You have heard the name of this surgery? This surgery is called Anderson-Hines pyeloplasty. Most commonly performed is Anderson-Hines pyeloplasty, and this is one of those age-old treatments which might be asked to an MBBS student as well. So, what is done in this? This is a dismembered pyeloplasty. Here if this is the site of obstruction, then in this surgery we dismembered the pelvis from the ureter. What does that mean? Dismember means we cut the pelvis from the ureter. Okay. We remove the affected part of the ureter and the pelvic junction, that is narrowed. We join the pelvis and the ureter like this in a dependent manner, so that this part of urine naturally gravitates the urine into the ureter. So, this operation, the full name is dismembered Anderson-Hines pyeloplasty. Okay. So, did you have a basic understanding of the commonly encountered congenital anomalies? Any questions in mind? Any doubts in mind? So, in the next class I shall be asking you a few questions and discussing the remaining part of congenital development of the bladder, testis, urethra and the associated anomalies. Okay.